Hello, my name is Roland from Kimmenade. I work as a cardiologist at the Department of Cardiology in the Radboud University Medical Center in Nijmegen, the Netherlands. And I will discuss with you the etiology of thoracic aortic aneurysms as part of an update from the 2022 ACC/AHA Aortic Disease Guidelines brought to you by the GenTAC Alliance. In 2022, the ACC/AHA guidelines for the diagnosis and management of aortic disease were updated, and as a part of that, I will discuss the etiology of aortic aneurysms. There's a difference between thoracic and abdominal aortic aneurysm because the diaphragm does not only divide the body into a thoracic and abdominal compartment, but also divides the aorta in an abdominal and a thoracic part. However, the aorta still remains one organ, but there are differences in complications of aortic disease in the two parts. For instance, in thoracic aortic aneurysms, an acute aortic syndrome usually presents as a dissection with the ascent of the intimal layer and is more associated with genetic backgrounds, while abdominal aortic aneurysms are more associated with classical cardiovascular risk factors, and an acute aortic syndrome of the abdominal aorta usually presents as a rupture. Focusing on thoracic aortic aneurysms, these occur in 5 to 10 per 100,000 person years and are located in the ascending part. That means the aortic root and the ascending aorta, which is in 60% of the cases. In the descending thoracic aorta, which is in 30% of thoracic aortic aneurysms, and only 10% or less of thoracic aortic aneurysms are located in the arch. The risk factors for the development of a thoracic aortic aneurysm are hypertension, smoking, hypercholesterolemia, and heritable genetic variants. In patients with a thoracic abdominal aneurysm have a moderately increased incidence of an AAA or cerebral aneurysms. If we look at associated factors, then we know that in root and ascending aortic aneurysms, there are heritable influences. They present at a younger age, can be associated with bicuspid aortic valve, because in a bicuspid aortic valve, there is a genetic background, but there can also be a hemodynamic factors that play a role, because in a normal tricuspid aortic valve, you see that the blood flow is laminar in the ascending aorta. While in a bicuspid aortic valve, the blood flow is more turbulent, which can increase the development of an ascending aneurysms. Furthermore, there can be sporadic or idiopathic forms, and optimal therapeutic decision-making may depend on the underlying cause. So it's important to further investigate why a patient or a family has a thoracic aortic aneurysm. So several causes of thoracic aortic aneurysms. There are the syndromical ones, with Marfan syndrome as the most known variant, but there are also non-syndromical cases, like, for instance, ACTA2 mutations. Furthermore, congenital conditions may result in a thoracic aortic aneurysms, and we already discussed the bicuspid aortic valve, but also Turner syndrome or complex congenital heart defects, which are mostly the conotruncal the defects, as for instance the troja flow, may result in an aneurysm of the thoracic aorta. However, this does not always result in an increased prevalence of acute aortic syndromes, since we know that aortic dissection and pathology of fellow is actually less prevalent than the rest of the population. Other causes are hypertension, atherosclerosis, degenerative, and previous aortic dissection may result in dilation of the aorta. Furthermore, inflammatory aortitis is causing thoracic aortic aneurysms, and also infectious causes may result in thoracic aortic aneurysms. As for instance, Q fever, which is actually a combination of an infectious disease with an inflammatory reaction causing aortic aneurysms. Previous traumatic aortic injury may also result in a thoracic aortic aneurysm. Looking more into depth in these causes, if we look at syndromic causes, Marfan syndrome is of course the most known one, and syndromal means that patients have not only cardiovascular disease, but the mutation may also result in complications in other organ systems, and in Marfan syndrome, especially ectopia lentis is well known. In Lewis-Dietz syndrome, which is related to Marfan syndrome, for instance, arterial tortuosity is more prevalent than in Marfan syndrome. Vascular adenomas, thin skin with easy bruising may also be associated. There are different other syndromes with different associated organ systems involved. Looking at non-syndromic causes, ACTA2 is a very well-known mutation which especially gives aortic diseases, but it's not involved in other organ system, and it's important to realize that the non-syndromic causes actually result in dissection at a younger age or younger size, or smaller sizes than we know, and this has complication for therapy. Bicuspid aortic valve is already discussed, and this is also associated with thoracic aortic aneurysms. And further on, we have the sporadic and degenerative thoracic aortic aneurysms, which, even if they are sporadic, present at a younger age than descending thoracic aneurysms, as you can see. And typical atherosclerotic risk factors such as hypertension and smoking are significantly less common in sporadic root and ascending aortic aneurysms. Interestingly, the prevalence of calcification in sporadic aneurysms of the root and the ascending aorta is not as high as in descending aortic aneurysms. In conclusion, there are differences in prevalences of causes for aortic aneurysms, and they depend on their location. Thoracic aortic aneurysms can be hereditary or genetic, and can be syndromal or not syndromal. They can be congenital, associated with classical cardiovascular risk factors. Inflammatory and infectious causes may play a role. They can be post-traumatic or even idiopathic. And antihypertensive therapy is key in the prevention of the development of an acute aortic syndrome in all causes. Thank you very much for your attention, and goodbye.